Thank you very much. It's hard to believe that I can actually verbalize 40 years as a respiratory therapist. It's a long time, you know. I don't look that old, I know, but. So I want you to, I have one, in all the years I've worked, the thing that has been my biggest and most enjoyable task is home ventilation. I love home ventilation. The interaction with the patients, the parents, the family, you almost become part of the family. And so it's a passion of mine, doing home ventilation. How many are in here work for a DME company? Cool. And how many are doing non-invasive ventilation? And how many are doing invasive ventilation? Okay, good. So we're going to talk about both non-invasive and invasive ventilation. And I have a bunch of my friends, some of the people that used to work with me, Mark Enlow, Jim Eddins, and my wife here, she keeps me straight. So anyway, let's get started. HQA, just a little brief thing since they're sponsoring me. We are an accreditation organization that has been granted deeming authority by the Centers of Medicare and Medicaid Services, and that's people go, well, who are you? I always say, well, we're kind of competitors like Joint Commission. We're not Joint Commission, but they're one of our competitors. So that's what we do. Session objectives. Define the steps required to provide mechanical ventilation in the home. Identify the regulatory bodies that need to be considered when providing ventilation within the home, and to discuss the business benefits that can result by providing home ventilation. First question is, what type of mechanical ventilation will you be providing? Is it going to be non-invasive or invasive? Non-invasive is pretty much the easiest one to do. It's not more than pretty much CPAP. It's a nocturnal use, and you know what that is. You're all respiratory therapists. Typically, the patients are diagnosed with COPD, respiratory failure, obesity hypoventilation syndrome, and sometimes ALS. There's a certain segment of ALS patients now that we have that are refusing to be trached. They want to be mass ventilated. We're going to talk a little bit about that later. Definition time. Invasive mechanical ventilation is a coarse ventilation that provides is provided through an artificial airway, such as a trach tube. And life supportive, it's a mechanical device that supports a patient. It provides improvement in the patient's health perception, clinical improvement. Life supportive is like oxygen, non-invasive ventilation, even PAP. They use it helps them support their life. It provides a better outcome to living, but it's not a dependency. Ventilator dependency or life sustaining, we're moving more away from talking about non-invasive ventilation as supportive or life sustaining. And patients that are in life sustaining ventilation, that means if they come off of it, they could die. And that's not the case with the non-invasive ventilation. So even in the manufacturer's literatures, they're starting to make some of that clear, because we're using the vents for both non-invasive and invasive. So, of course, I do survey, and I'll look at policy and procedure. And a lot of companies, when we talk about vents, and they're doing both non-invasive and invasive, they have one policy to cover both. And I always encourage them to separate those into a program. I have a non-invasive program and I have an invasive program, because it's going to be different. Your invasive program is going to be a lot more detailed and require a lot more policy than your non-invasive. So it gets confusing for the staff when you have them blended together, and the surveyors. Non-invasive ventilation can be initiated in the hospital or in the home. You're going to provide patient and caregiver training, follow-up consistent with frequently serviced item, and that's pretty much, these are the last categories of frequently serviced. And that means that Medicare pays for them throughout the life of the patient. And then we also, you have to make a decision whether you're going to do clinical services with it. It's really hard to not do clinical when you're doing vents. And some companies don't like you to do clinical. The owners, they think it's going to put them down a bad path, so they refuse their therapists from touching the patients. But in reality, when I go out on survey with the therapist, they take their little bag. And they say, oh, we don't do clinical. We can't touch a patient. And they open up their bag, and I say, okay, what's the stethoscope in your bag for? Why do you have a pulse oximeter? Because it's hard to take us as therapists and not have us not touch patients. So you should always consider adding clinical respiratory, and it's easy. Non-invasive prescription, it's going to be, most are for titration. I'm not going to read all these, but most are for titration to patient comfort or best therapeutic pressures. I typically hate the order for patient comfort because you get one of these pink puffers. Y'all know who pink puffers are, right? And they haven't ventilated their lungs fully in years. And you start trying to get up to the therapeutic pressures. Is that comfortable? No, it's not. It hurts. And so it's not comfortable. So we should be looking more at best therapeutic pressures. We get the orders to titrate, and one of the problematic areas is that sometimes we don't get an order after we finish the titration. We don't get an order for those set pressures and set rates. It's very important because why would you adjust a ventilator? You got them set 6 months, you still have this active titration order, and a lot of therapists will go in, they want to have that liberty to adjust the pressures if the patient gets sick. Well, there's a problem with that because if the patient's conditions change, who are we supposed to call? The doctor. So you should always, after you finish your titrations, you should always get a prescription with the set pressures. It does require an annual renewal of proof of continued need. And one thing you don't ever want to do is use that unit and just have the patient on CPAP or BiPAP. Medicare cannot, they don't like that, and they'll take your money back. So you're going to have your initial setup and training on your follow-up. You're going to do that probably in the patient's home. It happened more in the home now than it is in the hospitals. And then a lot of companies suggested follow-up to be 1 week follow-up, 1 month follow-up, monthly follow-up times 2. And then if the patient's tolerating and compliant, benefiting from the services, it's good to go back to, you can go to quarterly visits. Remember, you still, with Medicare patients, you have to prove that it's being frequently serviced. So that's very important that you make those. And that's kind of the standard of care in the industry for non-invasive vents. And what is the goal? I always put this up here. But the goal for non-invasive ventilation, most people will say to blow off CO2, right? But that's the outcome. The goal of the therapy is to rest respiratory muscles at night so the patient can maintain a lower CO2 during the day. Clinical respiratory services, a lot of companies are scared of it, but it's providing hands-on assessment and treatment within the home. Things like oximetry, auscultation, blood pressure checks, suctioning, trach change out, other physical type assessments and procedures. Clinical respiratory services does require physician prescription. One-time orders, you have to get one. Ongoing or PRN. Ongoing and PRN, you have to get them renewed annually. And they can be included with your ventilator orders, which I recommend. It's a lot easier to get them signed. And this, of course, it's going to be provided by clinical personnel. People ask me, well, how do I create that prescription, or what should I say in it? You always want to use words like may perform a clinical assessment with ventilator follow-up, and include everything you want to do, whether it's auscultation, trach change out, suctioning, blood pressure checks. But be sure to use the word may, because if you say you will or we will provide, or it becomes an order to do it every time you're out there. And so it allows you to have the opportunity to go. Patient stable, you go in, they're watching TV, eating dumplings and laughing and having fun, and they look stable, they are stable, there's no reason you may not need to do that clinical assessment. So it gives you the choice of whether to do the assessment or not. But if they're sick, you're going to do it, right? Invasive mechanical ventilation, the following diagnoses such as respiratory failure, this is what gets it paid. And I always like to include on my scripts failure to wean, have the doctor sign that and attest to the fact that the patient was not able to be weaned in the hospital. ALS, respiratory failure second to spinal cord injuries, chronic obstructive pulmonary disease, of course, Guillain-Barré, polio, diaphragmatic paralysis. Again, just like we did with the non-invasive program, we're going to develop an invasive program, which is great, and it's great to market that. Both the non-invasive programs can be put into marketing material and taken out to the hospitals. We were really successful with this at our pediatric hospitals when I worked at United Medical, and our marketing people would take the therapist out with the program that we had it nicely bound and looked good, and would go over our program with the pediatric doctors and nurses. You always have to verify benefits and reimbursement. You're going to initiate this therapy in the hospital, and you want to provide caregiver training in the hospital. Follow-up would be consistent with frequently serviced items as well as standard of care. You always want to do a home assessment to be sure that the home is suitable for the ventilator and the patient can be cared for. And then there's some companies that try to not do clinical services with invasive vents, but I can tell you it's very, very hard. Of course, you're going to have a clinician. Then you need to have, if you're going to do invasive mechanical ventilation, you want to have at least two, right? Because you don't want to be on vacation and have one of your vents crash, right? So you need two respiratory therapists or LPN, RN that's been trained in ventilation or home ventilation that can back you up. And then if your program's pretty big, you do need support staff because supplies are continually having to be ordered. So you have to have that support mechanism to help you keep up with the supply orders. On the IMV policy requirements, you're going to develop discharge procedures. How are you going to teach the patient? What you're going to do it for 5 days? You're going to do it for 3 days while the patient's still in the hospital with the family? Are they doing? Who's doing the training? Is it you? Is it the hospital, or both of you? It's really nice when you incorporate the hospital staff into the training and have them doing checkoffs on the caregivers as well. And you also want to do training on all the ancillary equipment like suction machines, concentrators, whatever you're going to be using to care for the patient. I went into one home one time about 3 years ago. It was a little bit before COVID, and I asked the caregiver, I said, well, how did you learn to suction your husband? And she said, by YouTube. I said, what? She said, yeah, we watched a YouTube video. And everything that she was doing with the patient was by watching YouTube. And of course, we had to back up and not allow them to do ventilation anymore until they could get their procedures and their staff trained and do the proper things with the patient. So, yeah, it does happen. You also want to do, you want to have emergency procedures and training for the patient caregivers for mucus plugging. If they decannulate their trach, those things need to be trained on. And you need to visualize that these patients know what they're doing. We also want to notify service providers such as electric companies, 911, that the patient's in the hospital on a non-invasive or on an invasive mechanical ventilation. IMV acceptance criteria is based on and the ARC clinical practice guidelines, and people say those are really dated, and they are. And I wish the ARC would revamp these guidelines. It'd be something really good to happen. I think they were published in 2007, if memory serves me right. But it goes over, the screening has to be done. Melissa, can you bring me my reading glasses? I'm sorry. But we want the screening. We want the screening to be done to ensure that the patient's appropriately trained and within the organization's scope of practice. Great, thank you. We want to look at their physical assessment of the patient, review their medical history. We want to set therapeutic goals, the home safety assessment. Also, we want to be sure, this is all of the clinical practice guidelines, but we want to be sure like patients aren't requiring more than 40% oxygen. And people ask me why. Well, because it shows the stability of the patient. Is a patient really considered stable if they require 60% oxygen? Probably not. And then the question came up last week about liter flow. Can we do liter flow? Yeah, you can do liter flow, but the rule of thumb is for every increase in oxygen by 1 liter, what percent does oxygen, the FiO2 go up? 4%, right? So they were asking me, could they go up to 10 liters? I said no, because you would be probably above that. And a lot of the new ventilators do have analyzers on them that can adequately show you the average FiO2 on the vent, which is really nice. Maximum level of 10, a PEEP, and again, just like you need 2 therapists, you need 2 caregivers, right? Because mama always has to go get her hair fixed and leave daddy at home without any supervision. I had one sad case where this was down in Florida. When I was surveying, there was an ALS patient being mass ventilated, and she had to go to the grocery store. And so she left him. And when she came back, he was dead. The mask had slipped some way, and so the patient failed to get ventilation. So that's the reason, 2 caregivers, that patients that are life-sustaining on, they need to be constantly cared for. Of course, your IMV prescription is going to have the ventilator mode, volume, rate, FiO2, or liters per minute, pressure support, PEEP, all the other parameters. And there's so many different types of modes of ventilation now with the new ventilators. But you want to have all that documented. And always refer to it. One of the problematic areas when we survey vent companies is that we'll go out and we'll take the prescription, and it gives our orders, and we go out and we look at the ventilator, and guess what? It's set differently, right? And the order had not been paid. Maybe the patient went to the doctor, and the doctor made a physical change on the ventilator and didn't notify the DME company. But then when I go back and look at the notes from the therapist, it's recording the old script instead of the new script. Okay, so you need to be careful. You have to be sure that you're consistent with that you're checking for new orders whenever you go out. Additional orders that you may be required, like pulse oximetry testing, oxygen, you're going to bleed in oxygen. Some companies are doing end-tidal CO2 measurements, especially if they're doing some weaning. They have weaning activities going on. And then the weaning activities included specific orders regarding taking the patient off the ventilator or changing settings for weaning purposes. So you need to be sure you have all that covered. And then, you should have goals. And once you get the patient to a certain weaning, you've got them down to a certain level that the doctor wanted you to get them down to, then you would want to get orders to continue the training or continue the weaning. The IMV backup. A second ventilator is provided for patients who cannot maintain spontaneous ventilation for 4 hours or more. That's right out of the clinical practice guidelines. And do we have a ventilator always do we have a backup ventilator when you have a patient on a ventilator? You have an ambu or an ambu bag, don't you? So that can act as help for you until you can get a ventilator there. Second ventilators are provided for patients who live in areas where replacement ventilators cannot be provided within 2 hours of the patient's home. Also included in here, but it's not always the case, especially with Medicare, them paying for a second ventilator to go on a chair when a patient's chair bound. And so Medicare's pretty much stopped doing that now, because used to be back in the day when we did home ventilators, since they were 55 pounds. The units they were huge boxes. And now, how big are they? Tiny. So they can easily be put on the back of a chair, and they're very mobile. You should always set up your policy, some type of ratio, like 1 to 5. You're going to have 1 ventilator on backup in your office for every 5 that you have out, or 1 to 10, but so that you can keep your stock going, and the people who are doing your support, supporting you, keep an eye on your inventory. They can help keep an eye on that too. You don't want to have an issue where you need a vent and, oh my, we put it out, the last one out this morning on a patient, and now we've had one go out. So you always want to have enough vents on backup to support your current patients. If you're renting, a lot of companies are leasing ventilators now. How many people lease ventilators? Well, one. So if we lease ventilators, you need to have some type of understanding of how keeping some on backup in your office, or how soon the response time is. I've got a company down in Dallas that they can get them within an hour. That's fine. You know, they can use that, but they have it in contract that they can get them that fast. Caregiver training starts at the hospital or facility. Again, it can be done by both the facility or the hospital staff and you. Should never be rushed. You don't want to push it. You want to be sure that caregivers are ready to go home. It's always good to communicate with discharge coordinators and physicians about your progress. You're going to document both caregivers. A lot of times we see where only one caregiver has been documented training. You want to have both. You want to have documentation for both caregivers. And use the manufacturer's caregiver checkoff as recommended, because the manufacturer, remember, everything from manufacturer is FDA approved, right? And so that manufacturer said that this is the level of training you need to do with a patient or caregiver that's taking a patient home. The IMV home assessment is very important. You want to do it as soon as possible, because if there are things that need to be corrected at home, you're going to have time to get them corrected. You need to inspect the room where the patient will be residing. Is it large enough? How's the lighting in there? Do we have enough electrical outlets, or is electricity adequate? If they turn on the microwave, the TV fails because they blew a circuit breaker, right? You don't want that situation to happen. There's a lot of companies that won't take patients home unless they have a landline phone, and mainly because of the 911 issues and cell phone coverage, especially in the real rural areas. We live in a rural area, and before we had high-speed internet, we'd have to go and could do IP calling through our internet provider. We would have to go out in the front yard sometimes to make a cell phone call with your umbrella, like Green Acres. You want to note how the number of people in the household and their ages and the proximity of the caregiver's room. You know, if the patient's downstairs and it's a 2-story house and the caregiver is upstairs, that's probably not a real good scenario. We always like to take patients home on Monday, because if there were problems, I didn't want to take them home on Friday because we had done this before and we had problems. We couldn't get a hold of the physicians. And it's even harder to do that now. So I would always suggest taking patients home on Monday, so you have a whole week to work out the kinks. You should always set up equipment in the home prior to discharge. You want to give it kind of a test to see if everything works, and you don't lose electricity if you turn on the suction machine. You have the ventilator on at the same time, and then you should be there when the patient gets to the home, and you want to be sure that they're comfortable, and you go over some education things, be sure that everyone is comfortable with what they're doing. This is kind of the standard of care I see out in the field, but there's usually several follow-ups the first week, up to 3, 2 follow-ups the second week, 1 follow-up the week 3 and 4, monthly thereafter, and documentation of all visits when you go out. It's really sad when companies don't document that they have gone out to see the patient, but it happens. And with this type of follow-up protocol, you're sort of weaning the patients and the caregivers away from you and letting them know they can do it on their own. So in your follow-up, when you go out to do your follow-up, not only are you going to be writing your settings down and checking all that, you'll be checking the equipment to be sure it's working properly. You're going to assess the patient's tolerance of the ventilator. You want to look at all the related equipment, be sure they have their battery backup that they need. All the ventilators still have a method of hooking up a deep cycle marine battery, and those are recommended, especially in areas where they may be real rural. Just as an example, we're at the end of the line for the electric company. So guess who gets their power on last? It's always us, because we're just that one person where they can get power on to 30 or 40 people. When you go out, you should assess for supplies. Be sure that they're changing their circuits and changing their equipment or their soft goods on a regular basis. Always like to have them, when you make your visit, take enough where they have 6 weeks worth of supplies. In case for some reason you're delayed in your return, you're going to have that 2-week cushion to be sure they don't run out. You also want to look at their trach tubes. You want a backup trach tube, and then one size smaller, in case they can't get it in, they can slip that smaller trach tube in. You want to be sure they have access for a manual resuscitator with a mask, because if the trach comes out and they don't have a mask and they can't get the trach back in, how are they going to ventilate the patient? They're going to have to use a mask. And always assess for new safety concerns. This happens a lot. We take patients home, even with just oxygen patients, in the summertime. It's hot, it's 100 degrees. They have a big fireplace. And then when we go out for our visit in the wintertime, when it starts getting cool, around Christmas, they have a warning fire in their fireplace. They have candles, because it's around Christmas. And all those represent a risk, right, when you're on oxygen. So you always want to look at that every time you go out. So, special consideration, and this happens a lot more than you think. So, and ALS is a terrible disease. One of the hardest diseases that I took care of patients with, because it was there was so much, they weren't going to get better, and it was only going to get worse. And so I really struggled personally with those issues with ALS, but I took care of a bunch of them. So these patients that choose not to continue with, they don't want to be intubated, they don't want to have a trach, they want to be mass ventilated. At some point, you're going to go out there to see them, and it's going to be life-sustaining. It was life-supportive at first, but now it's life-sustaining, right? If they come off the vent, or if the mask slips, they will die. So when that happens, and if you look at the manufacturer's books, the manuals now, they talk about this difference. So once it becomes life-sustaining, you have to treat it not like a non-invasive vent, right? It's got to be treated like what it is. It's an invasive vent. So you need 2 caregivers, you need all the backup, you need everything you need to take care of that patient. So I go out to a lot of companies that have non-invasive vents, and they're treating a fair number of ALS patients. And I'll say, when it becomes life-sustaining, what are you going to do? Are you going to take them back to the hospital, or what are you going to do with that? Because they refuse to do the invasive mechanical ventilations. So it's a decision you need to make on the front end in your business of how to handle those patients, and what you're going to do with them. In my opinion, if you're going to do ALS patients, you should be doing invasive mechanical ventilation as well, because it's going to end up being life-sustaining. Recommendations: start the program out slow. Don't be in a big hurry. A lot of people want to jump into the pediatric market. I always like to start out in the geriatric market. Pediatric market is very hard to crack. Those children in hospitals, they're really particular who they're sending their babies home with, and rightfully so. You have to prove that you can take care of them. Always, like I said, it's hard not to do clinical services when you're doing invasive ventilation. Try to hire experienced clinicians, which clinicians are hard to find now, nationwide. It's just hard to find respiratory therapists. There are not that many out there. And they cost a lot more than they used to as well. Use manufacturers, and all the manufacturers' documentation, they have competency assessments, and your therapist should be competent assessed using those assessment tools. Because again, that's what the manufacturer is saying, that you need to be competent to do a setup of a ventilator. So use their manufacturer's guideline, the manufacturer's competency assessments. All the ventilators have some type of checkout procedure. y'all do checkout procedures on your, document checkout procedures on your vents before you put them out on patients? You should. Sometimes that's a missed documentation that people don't, they forget to document that they actually did the check on the ventilator before they set it up. Develop a tracking system for the required maintenances. And consider if you're going to do this, thinking about doing invasive ventilation, there are some canned manuals out there that are pretty good. And you can buy those and personalize them to your own business. And then you should consider a consultant as well if you're really, really green to it. Accreditation concerns. This is, we have companies call me all the time and we're thinking about doing invasive mechanical ventilation, but we're worried we'll lose our accreditation. So if you design your policy and your procedures and you do the right things, you won't have any accreditation concerns. So the policy procedure is a must with invasive mechanical ventilation. And usually I always get worried when I open their company's workroom and they have 3 pages of policy for their ventilation program. It's usually quite thick, 20, 30 pages long in some cases. You want to get the appropriate licensed individuals to be involved. You need to review the Respiratory Practice Act in your state or all the states that you're in to see what it says about mechanical ventilation. And if there's any specifics, be sure that the scope of practice that you're going to offer is within guidelines. Only use those who have proven competencies and are assessed as required by policy and AO standards. Accrediting organizations like HQA, we all have our own standards about how often the competencies have to be performed. We do them every 2 years. That's our standard. There's some that still require annual competencies to be performed. And you also want to review the DEMA Post Licensure database, and I've got a link for this at the end of the show or at the end of the presentation, not a show, but at the end of the presentation, for you to review that to see if there's any specific other licenses required for mechanical ventilation. The marketing and financial benefit. Again, develop the program so you can market it, okay? And for most part, ventilators are the items requiring frequent and substantial servicing, which means it's being paid for the lifetime of the patient. We used to have a lot of items like that, like oxygen, right? It used to be frequently serviced, and so we could get paid for oxygen back in the day as long as the patient was alive, which was nice. And we got paid like $400 for it a month. That was really nice. Not paid that well at all now. You have a lot of add-on equipment such as oxygen and beds, wheelchairs. Sometimes complex wheelchairs come with the patient, and just for the vent, the reimbursement's around $1,100 a month, depending on where you live. Here are the links. I have the link for the ARC practice guidelines. Which I don't know if you know, there's 2 different standards with Medicare. There's quality standards and there's supplier standards. And the quality standards actually state that you're supposed to have availability to the clinical practice guidelines within your practice or your office. So I always like to have those for my therapist in the office so they can review them. There's a fee schedule link, and then again there's a DEMA Post Licensure database. And then we have a resource that on our resource page at HQA that you can click on, and it gives you every state Respiratory Care Practice Act by state on the link, so you can look it up that way. Thank you very much. Hope you enjoyed it. Are there any questions? No questions? Okay. Well, you have my contact information. If you have questions or want to talk to me after the presentation, that would be great. Okay. Thank you.